Hello, everybody. Before we get started, I would like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed for you. We welcome your questions and you will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of your attendee control panel. You can send your questions in at any time during the presentation and we'll collect these and address them during the Q&A session at the end of today's presentation. We have a fabulous speaker for you today, Dr. Frank Papay, Chairman of the Dermatology and Plastic Surgery Institute. Frank Papay is an accomplished surgeon, has been recognised as one of the nation's best doctors specialising in plastic and reconstructive by Castle Connolly. He is currently chairman of the Cleveland Clinic Dermatology and Plastic Surgery Institute and professor of surgery, Lerner School of Medicine of Case Western Reserve University. He is head of the section of craniofacial surgery, director of craniofacial surgical fellowship, and leads the multidisciplinary craniofacial cleft palate surgical center of the Cleveland Clinic, and is the craniofacial surgeon member of America's first face transplant surgical team. His clinical research interests include the design of medical devices, biomaterials in craniofacial reconstruction, nasal valve function in rhinoplasty, facial aesthetic plastic surgery, pediatric craniofacial anomalies, surgical techniques, and virtual augmented reality for the face transplantation and neural modulation of skull-based ganglia for clusters and migraine headaches. Dr. Papay has been awarded the WebMD's 2014 Health Hero for his work with migraine headache technology. He was the 2016 Ohio University Medal of Merit Award recipient and the 2017 Northeast Ohio Medical University Outstanding Alumnus Award. He was inducted into the National Academy of Inventors class of 2017. Dr. Papay has served as president of the Ohio Valley Society of Plastic Surgeons, chair of the American Society of Plastic Surgery Ethics Committee, president of the Plastic Surgery section of the American Academy of Pediatrics, and vice president education of the American Society of Maxillofacial Surgeons. He also serves on executive committees at the Cleveland Clinic in his role as institute chair. First trained as a biomedical engineer, Dr. Papay subsequently became double boarded in plastic and reconstructive surgery. He's published over 200 scientific papers, abstracts, and book chapters, and is the primary inventor of over 40 medical device patents and patent applications, in addition to a very long list of innovative surgical procedures. He has served as a senior board examiner for the American Board of Plastic Surgery, finalist judge for the Collegiate Inventors Competition from the National Inventors Hall of Fame, and the advisory board for the University of Akron Biomedical Engineering Department, and invited section reviewer and or editorial board of several plastic surgery scientific journals. Dr. Papay is also a member of Cleveland Clinic's Innovations Commercialization Board, former member of the Board of Directors of Jumpstart Inc., and sits on a number of medical advisory boards. He is also co-founder of Cleveland Cares Medical Missions and has participated in multiple overseas volunteer surgical missions for craniofacial and cleft palate reconstructions. Dr. Papay has co-founded a series of Cleveland Clinic new ventures and is an executive member of their board. Dr. Papay is currently completing his Doctor of Management degree at the Weatherhead School of Management, Case Western Reserve University, with his thesis involving the entrepreneurial process of risk transference in the due diligence and decision making of financing new biotech ventures. So it is my great pleasure to introduce your presenter today, Dr. Frank Papay. Dr. Papay, please do go ahead.
Well, thank you very much. I'd like to first of all thank Dr. Rosenthal for the kind invitation to present what I think is sort of the frontiers of fluorescent guided surgery. I'm somewhat of a neophyte. I've used fluorescent guided surgery quite a bit with a large number of plastic surgery reconstructive efforts, in particular with perfusion. But I've been involved with Dr. Yang Liu from the University of Akron Biomedical Engineering Department in looking at different ways that fluorescent guided surgery, in addition to new technologies, can be combined to go to the next level. And that's what I'd like to talk about today. Because of that, I do have some conflict of interest. I'm a co-founder of a spinoff of the University of Akron with Dr. Liu, Unified Medical Inc. And what really that is really improving surgeries through augmented reality. And we'll talk a little bit about that near the end of this. What I like to talk about is, and again, my apologies for those that are experts on this, is really the clinical need, the market outlook, and then what is the future in the probes that we use for fluorescent guided surgery? How can we advance and augment the visualization of the surgeon and physician, utilizing virtual reality, augmented reality, and mixed reality? In addition to crunching that data collection to assist in decision support and see what's close, not pie in the sky, but what is in the near horizon. Let's first look at the market of all medical imaging, and especially in surgical devices. And as you can see, it's growing at around 6 to 7% per year. And worldwide, I think the market is probably over $6 billion at this time. In fluorescent guided surgery, if we just look at the amount of publications, they have progressed exponentially. And at this point, there's well over 2,000 fluorescent guided surgery publications to this date. Well, what are the economic drivers? Certainly, healthcare, at least in the United States, is still increasing at around 78% per year. And so the goal of that is to really pace that and slow that down, if not reverse it. Right now in the United States, healthcare is the number one market, the number one expenditure by the government, short of the military, and that you can argue is the number one part of the highest percentage of the gross national product in the United States. So why fluorescent guided surgery, and what is the value proposition of such, and how will that change to make things faster, better, and less costly? Well, first of all, it enhances the tissue differentiation to reduce procedural time and cost. Again, in the United States, the operating room, at least at the Cleveland Clinic, for every 15 minutes in the operating room that you save time, that is worth anywhere between $1,000 and $1,500. So again, enhancing tissue differentiation, at least visually, to know what to cut and not cut, would save a lot of procedural time and cost just in the OR alone. Also, in the long term, to reduce patient morbidity, to improve decision making, again, with surgical planning, intraoperative decision making, and safety, will also improve cost in the long run through better outcomes. So what are the clinical needs for fluorescent guided surgery? Well, one is certainly to augment the surgeon's senses, not just vision, not just what we see, but perhaps also hearing. And we'll also talk about that later on. To differentiate the tissue types. What is tumor? What is non-tumor? What's the blood vessel? What is not a blood vessel? What's the blood vessel versus a nerve? To overlay different types of integrated images, such as radiologic images of CT scans, MRIs, PET scans. And also to do real-time visualization. Every time you move a patient, you have to recheck the relationship of that patient's current position as it is to the CAT scan or MRI or PET scan that you're overlaying on to that patient, currently with fiducials, but can you do it without fiducials? and something that is easy to use and over a long period of time. So the wearability of such instrumentation is important. Certainly the cost effectiveness, will it improve the clinical outcome, and will it also improve safety, not just to the patient, but to the caregiver? So the applications of optical probes, and the basis of it is really is giving intravenously. That's the most common access, but we'll talk about different ways of inducing optical probes for both preoperative diagnosis and planning. And then also, more importantly, what we use in particular with fluorescent guided surgery is utilizing it in vivo for surgical guidance, and then ex vivo for topical probes for pathology. I think the next level of this is going to advance what I call the personalized precision therapies. And these are molecular probes diagnostics that are utilized not just for surgical guidance, but for intraoperative decision making, and even adapt targeted therapeutics with fluorescent guided surgery to treat the patient at the same time you are surgically guided to those particular tumors or whatever you're trying to target. The slide on the image on the right shows the molecular probes and the differentiations of these probes as compared to the hardware that we are currently advancing to utilize to monitor these probes. And then in the middle is really how we can use this for this precision personalized therapy, in particular molecular guided surgical oncology methods. There are three major fluorescent probes. There's the passive probe, which is ICG, fluorescein, and other particular stains. There's the metabolic probes, which I'm interested in, and particularly the most common is alpha levulinic acid, and activatable probes that can be used to activate once they reach their target. And then targeted probes that can be carried by either cells such as macrophages and/or other um, sort of carriers to particular targets, such as monoclonal antibodies. Right now, the FDA-approved fluorescein probes are indocyanine green, being probably the most commonly used, with methylene blue. For those that are activated onto the patient by increasing the porphyrin, autofluorescent is 5-alpha-levulinic acid, though in Europe, several other activated porphyrin probes are being utilized. In the expense of these, it seemed to be increasing year by year. Fluorescein has been used for some time, fluorate, in addition to some other IR dye probes have been used. The fluorescein systems are the fluorescent systems that currently are on the market, at least in the United States. The most common of which that we utilize at the Cleveland Clinic is the Novadex Spy device. The Quest is up and coming, and that's out of Western Europe. And we also have been using the Quest Spectrum device, especially for guided surgery, in particular for perfusion. But also our ablative soft tissue oncology surgeons are also utilizing it for melanoma resection, sentinel lymph node biopsies, and breast cancer surgeries. So if we look, I think it's so sensitive. Let me back up a little bit. If you look at the approved fluorescent systems and the FDA number that has approved them and what they were indicated for, most of them were indicated for first with perfusion. And very few were approved for any targeted therapy, but by secondary nature and utilizing it off-label outside of the perfusion is where most of the advances are occurring right now. The competitive analysis of these fluorescent guided systems show, as compared to each other, what are they utilized for, what are their sort of competitive advantages as compared to each other. As you can see, what they're missing here, if you look at this slide very carefully, they all are fairly large systems. There's a few handheld systems, but none of them are wearable systems. In addition to that, none of these systems really have augmented reality associated with it on top of the fluorescent guided surgery in registration to list the area of integrated images on top of them. So what are the clinical applications for such? Well, right now there's around 60 clinical and 16 preclinical applications for fluorescent techniques. And here's a list of them. The most common that, again, we use in plastic and reconstructive surgery is perfusion, but in the soft tissue oncology world, in addition to plastic and reconstructive surgery, we also utilize it for sentinel lymph node biopsies and lymphography plus angiography. In the tumor imaging, one of the more common areas that I see have been in breast cancer surgery and also in neurosurgery in particular, utilizing alpha levulinic acid to augment the differentiation between tumor, i.e. gliomas versus normal brain tissue. And you can see there's a list here of multiple different types of tumors, including, again, in my institute, skin cancers, sarcomas, in endocrine surgery and parathyroid differentiation as compared to the surrounding thyroid tissue. So again, a lot of different indications for fluorescent guided surgery, of which can be augmented down the road by overlaying or integrating different images in registrating the tumor as compared to the body's position. As far as the CPT procedure codes, this is just a list of a few of them that we utilize. So the payment of such is really the procedure that you're doing that is augmented by some type of CPT code that's going to add further utilization mechanisms of fluorescent guided surgery. To continue the value proposition of fluorescent guided surgery, what it really does is just increases the visual perception of the surgeon. And this graph on the right shows a list of surgeons that looked at, again, the tumor on the patient itself in white light and could differentiate what is tumor and not tumor just by the normal vision of the surgeon, and then looking at the same area through fluorescent guided surgery and to count the number of tumor visible spots. And as you can see, the number of spots detected was quite a bit more. So therefore, just with our normal vision, we're missing quite a bit. And so we augment that by tagging with fluorophores the tumors in of itself. So again, we're just augmenting perceptions at this time. So how do we create a better, if not an ideal, fluorescent surgical system? Well, one way is to perform real-time overlay of both white light reflections on the surgical field that you're creating, in addition to the fluorescent guided images, and overlay them together. Second is the fluorescent mode operation can be used with normal light rather than shutting the light off and on back and forth, which we commonly do in the SPY, excuse me, the SPY Novadex system. To look at the probes, to look at ways of increasing the sensitivity of the tracer of interest and how we can penetrate the tissues even deeper than infrared at this time. The ability to quantize the amount of fluorophores within the patient and on the target. So we can see the concentration of the target fluorophores that may be significantly correlated with the malignancy, with the size of the tumor, and other characteristics of the tumor. The ability to use multiple fluorophores at the same time, one targeting one particular antigen or one particular metabolic activity of the tumor, and another one that you could utilize for non-tumor, and then again to overlay those together. To maximize ergonomic use, right now these large units, you're pulling it in to the patient. It's hard to angulate, i.e. such as if you're doing a sentinel lymph node biopsy in the axilla, you've got to target not just the the visualization of the surgical field, but also target the light frequency that you're utilizing to activate these fluorophores, and to integrate the images. And one way of doing that would be through augmented reality, but also you can utilize enhanced decision support by knowing what's happening to the patient at all times. And this could be performed by looking at what's going on with anesthesia, that could be integrated into the images, or utilizing artificial intelligence or machine learning to analyze not just what you're seeing, but with increasing sensitivity, analyze through image recognition and onlay that onto your image itself, in addition to a possible audible probes. And then the last, which I consider is the holy grail, is real-time registration. The patient's surgical field is moving all the time. In some instances, it's pulsating. When you move the patient, whether it's a limb or you're rotating a patient to get a better field of view, registration is really important to lock in any integrated images that you're onlaying onto that patient. So to me, the last two are probably the most important to me in the future of fluorescent guided surgical systems. And here's an example of a tumor within a liver that is not superficially seen, but approximately about a centimeter below the level of the surface of this liver. You would not see this if just looking at the liver itself. So to differentiate that, you need to penetrate that liver with the activating light frequencies. You want to make sure that the fluorophores are getting to those particular areas. And in addition to that, you can see in the upper left of that image the patient's blood pressure, and the time. And so things like that can be integrated within the image during fluorescent guided surgery. So the challenges are really in the operating room, where looking at multiple monitors on the wall or in front of you while you're operating is not particularly safe. It produces poor hand and eye coordination. There's really no depth perception because you're having a 2D display either on the wall or in front of you. And it produces a more complex workflow if you're bringing in light sources, bringing in imaging cameras, and then bringing in the displays. It makes the operating room more complex and noisy quite a bit. And what that does, much like a pilot, that produces poor situational awareness. If you're a fighter pilot, you need to know what's going around you, in front of you, and back of you. You can, through radar, in addition to audibles, know warnings that are going on during a battlefield. Well, we need to do the same thing in the operating room. We need to have increased situational awareness through a multitude of technologies. We do have the concepts. And we do have the technologies. Not that we're like Iron Man, where, as my twin boys, it's their favorite. It's because he's a regular human being. He's not a superhero, but through his intelligence and through his augmented technology, he becomes a superhero. We have cell phones, we have ear pods, we have um, uh, magnification through surgical loops. So how can we combine all that together in addition to fluorescent guided surgery to really look at a patient, or in this case, we're looking at this animal here, and onlaying images, much like Iron Man did in his sort of situational awareness while he's flying through space, and really see these things as we're operating. Well, let's start with the basics. Really, the basics of a fluorescent system is near infrared imaging. And the components of that is the infrared light, which is the excitation part of the instrumentation, the collection optics that will filter the frequencies that we're utilizing, a video camera that will pick up not just the infrared, but other video cameras looking at the visualization of the field in of itself, and then computer and imaging display systems. Our current optical imaging systems does have advantages. They're rapid. You can inject somebody with ICG in a matter of seconds, see the effect of it. There are a lack of FDA-approved contrast agents, but they should increase, and the complexity of those contrast agents should also increase. And hopefully this will eliminate the radiation. Right now, when we perform a sentinel lymph node biopsy, the patient goes down to nuclear medicine, gets injected with technetium. They look at the lymphatic flow into the sentinel lymph node basin. And then from there, the patient is sent to the operating room. And again, utilizing really dumbed down gamma counters, we will follow that tracer into the area of the basin to explore. That all can be eliminated. Pretty much nuclear medicine in that process could completely eliminated, which would produce safety not just for the patient, but also increase safety of in obviating the need for radiation for the healthcare giver. Right now, there are limitations. The optical characteristics of many of these optical imaging systems lack particular characteristics to the tumor that they're trying to identify. There's a lot of absorption of the tissue in addition to scattering of the illuminating light. We'll talk a little bit about how to improve that. And there's limited sensitivity and spatial resolution. So how do we improve both on the probe end, the fluorescent probe end, and on the instrumentation and detecting those probes? Well, let's start with the probes. A simple probe, as you know, exhibits a photon when it's excited. It gets excited, goes into a different level, and when it drops back to its ground state is when it releases a photon, and that photon is picked up by a camera. And the most common of which is certainly ICG, which does this under an excitation light of around 760 nanometers and exhibits a fluorescence of 820. Other common passive fluorescent probes, again, do the same thing. In particular, the protoporphyrin is sort of an autofluorescence that is also excited by the protoporphyrin through other drugs like alpha-levulinic acid. But again, fluorescein, methylene blue, in particular, the most common at this time is ICG. So let's look at the activating porphyrins, the autofluorescent that is induced by alpha-levulinic acid. The most common of which is really differentiating normal brain versus tumor brain, in particular gliomas. And the higher the grade of the glioma, the more of a propensity for it to fluoresce under ALA because of the higher concentration of porphyrins. And this slide here shows you an example of the brain as it appears under normal visualization. Tumor versus non-tumor is very difficult to distinguish. But on the image to the right, you can see that it lights up quite a bit, with the edges being sort of gray, not very good contrast, but you know at least the center of that target of a glioma is in the region there as compared to the normal. So it does augment our perception. But again, I think improvement needs to be on the contrast. And there's some differentiation also in the grade of that glioma, as you can see by the histologies in the lower part of the panel there, A through D, D being the most malignant, and that induces the largest concentration of porphyrin, which induces the increasing fluorescence of the target. There's also sprayable fluorescent probes, and this is, again, a rat study looking at tumors within the bowel region over ovarian cancers. And this could be particularly important for endoscopic guidance and examination of a patient that have either an ovarian cyst to rule out ovarian tumors. There's also multifunctional nanoparticles that can be fluorescent. In particular, those, in this case, utilizing a silica cord with a radio opaque tantalum that can be both radio opaque in addition to fluorescent, that can be used for guided surgery, in particular AVMs and other vascular anomalies. What I'm interested in is the activatable fluorescent probes that can be both intracellular and extracellular. These are particularly important for targeted tumors in the fact that they can be brought into the cell and then activated through a series of metabolic activities or through an antigen on the surface of the cell be activated. Here's an example of one. This is one utilizing a HER2 antibody that has a fluorescent probe on the side. And you can see again in this mouse a specimen that has two tumors, one that has a tumor that is HER2 negative and one that is HER2 positive. Both of them on normal fluorescent will pick up some increased activity, but you can separate the two that is HER2 positive by having this activated fluorescein probe. There's other ones that will not sort of activate the fluorophore, which is guarded by a quencher, and this is an example thereof of how they are sort of linked molecularly and how they can separate once they attach themselves to the cell. Again, so this is increasing more and more, though they're not quite on the market yet. What the fluorescent guided systems should be are basically the picks and shovels to these gold miners that are out there looking at ways to have specific targeted fluorescein probes or fluorescent probes with high sensitivity and high specificity. Another way of looking at probes is really tagging a cell, i.e. a macrophage. As you know, macrophages can be propagated through the lymphatic system, and these can be used in, rather than particular particle size fluorescent probes such as fluorescein or methylene blue, but these can be used for actual cell migration into the lymph node. And here's an example again of an inflamed normal node that lights up with ICG. But on the bottom is one that is a metastatic node that is using a macrophage that has been tagged with a fluorescent probe that it now targets specifically that area of a sentinel lymph node within that particular animal. So again, molecular probes that are currently being explored for utilizing for intraoperative guidance are antibodies, peptides, the activatable probes utilizing proteases, and non-specific, as we talked about, that are more metabolically oriented. One of the issues with fluorescent guided surgery is the background noise. That you want to sort of separate the fluorescent probe from the surrounding fluorescence that is induced either by just a perfusion with fluorescent particles within the tissue itself. So one way of doing that is having a sort of a subtraction mechanism that will induce a higher contrast. In this case, this is an in vivo tumor detection with a targeted activatable fluorescent probe, again with this HER2 positive lung met model in a mouse, as compared to a normal fluorescent probe. And they're subtracted from each other that can, again, produce a more contrast to what is tumor and what is not tumor, separating the background noise ratio of the other parts of the fluorescent imaging system. How do we penetrate the tissue to really target these tumors in a much deeper manner? Well, what happens is when light travels through tissue, it can scatter, it can reflect, and only a fraction of it really truly absorbs to the area of the target. A lot of it's just carried away through the blood vessel system. So the absorption of light, again, it varies through the components over the wavelength spectrum. And that is why, and most often, we utilize in fluorescent imaging near infrared because it penetrates anywhere from 650 to 900 nanometers, much deeper. In most cases, a little over a centimeter as compared to the shorter wavelength lights. So how do we penetrate it in the human body. Again, the image in the upper right shows a breast with a near infrared around 600 to 1400 nanometers. And about the most that we can utilize, at least in a soft tissue such as a breast, is around 2 to 3 centimeters transcutaneous penetration. If we use other applications, such as optical coherence at a higher nanometer frequency, we can, again, penetrate a little bit deeper. So again, as we interact with the surface of something and we want to target the fluorophore, again, utilizing near infrared is probably the best way to go about it. But again, I think what we need to do is find ways of reducing the amount of absorption, scattering, transmission, and reflection. And one of the ways of doing that is, again, changing the wavelength to near infrared or longer if need be, to utilize superpulsing, to increasing the power intensity of that light, to change the tissue contact of that light in other factors such as polarization and coherence. One of the ways of doing that is utilizing a laser. And as you can see here, utilizing an LED with a light frequency around near infrared versus SLD. But if you use an 830 nanometer laser with a higher intensity, that can penetrate up to around 5 centimeters. And then there's simple compression techniques. And this is a trick that was taught to me by Dr. Steve Gromeyer when he performs a sentinel lymph node biopsy. He uses a cup-like technique that sort of compresses the soft tissue within the axilla to allows that distance of the activated light, the near-infrared light, to get to the particular fluorescent sentinel lymph nodes. And as you can see here, it's not really changing the light, it's not changing the fluorophore, it's just condensing that area of the path of the light to the tissue that needs to be activated and the fluorophores that need to be activated. So how do you filter the scattered fluorescent noise, and how do you merge this with the white light images? And again, this is an example of a necrotic tumor in the brain, and again, you can't tell what's tumor, what's not tumor. You kind of know what's necrotic, what's not necrotic. But again, how do you increase the contrast thereof? Well, one of the ways is really to really change the way the photons are perceived by the camera, and utilizing, again, what is perceived by the human eye versus perceived by the camera. And as you can see here by this graph, the camera sensitivity is much, much greater, particularly in the infrared system as compared to the human eye. The human eye can only see somewhere between 400 to around 700, and beyond that it can't. So, seeing what we can visually with white light and in inducing that with high intensity infrared light and onlaying onto each other would increase the way that we perceive these tumors. An example of this is as in this paper, looking at again liver mets and seeing on the surface really not much, but as we induce with near infrared into a deeper probe, and then onlaying that onto the normal visualization image and overlaying this together, integrating them together, you can see this tumor not just on the surface, but deeper. So integrating images with gated light spectrum will increase the contrast, but can you do this in real-time registration? And one of the ways, again, in this brain tumor, in this animal model here, you can see the increasing images, not just from fluorescent guided surgery, but as you induce the contrast by gating the color map that will be visualized, and then that will need to be tested to see what's tumor and non-tumor is a way of going about it. These are early in experimental animal studies looking at ways to increase the contrast of fluorescent guided surgery. Here's another example of that, again, looking at white light versus different pseudo colors of fluorescence in this particular mouse model. So integrating white light and selected lasers is another way of doing it. in emerging images with white light and near infrared to look at what's perfused versus what's not perfused. And this can be commonly used, especially in colon rectal surgery, as you can see in this one image here. So what's on the horizon? Again, I think we have influencing technologies, not just with the probes, but also utilizing multimodal optical imagers in surgical microscopy. One of the spinoffs from University of Akron is Unified Medical, and that's looking at fluorescent guided surgery and augmented reality, and in addition to real-time registration. We're producing this through what we call digital loops, in addition to other modalities such as ultrasound and co-registration. As you can see here, looking at blood flow through this tissue, at this animal model, looking how you can differentiate from venous to lymphatic to vein systems, and also applying this to fiber optics, in particular, scanning fiber optics in brain tumor resection. And perhaps in the future with hyperspectral imaging versus multispectral imaging, looking at packets of frequencies that we can look at, or a whole spectrum, which would be hyperspectral, and looking at sort of the 3D fingerprint of different, not just the surface, but deeper to the surface of different tumor types or different activated surgical fields. So optical spectral navigating probes are also, I think, the future, and that is looking at the fluorescent images and intraoperatively utilizing spectroscopy, which kind of relates to hyperspectral imaging, looking at the metabolic composition of tissues and utilizing this reflectance spectroscopy to analyze what type of tissue and characterize those tissues, i.e. tumor versus non-tumor, or just nerve versus non-nerve, et cetera. And how do we do this with a handheld probe in real time in surgery? Well, certainly the key to that is registration and real-time registration, not just of the patient itself, but also the instrumentation and the probes that you're using. And here's an example of a spectroscopy looking at, in this case, a form of multispectral imaging, what's normal brain and what's dense cancer. And you can see the spectrum and how the wavelength is reflected back is quite a bit different. And this can be characterized into more highly accurate detection of cancer in situ in the OR with, again, this multimodal optical spectroscopy that can be attached to imagings. I think artificial intelligence and image recognition is the future and ways of contrasting what is tumor and not tumor. Here is a parallel video stream of a colonoscopy, again, showing what you would see normally, but how that can be contrast utilizing augmented reality. So if artificial intelligence, which is truly image recognition, can differentiate tumor, then I think robotics can learn what to cut and not cut. And certainly Intuitive, which produces the Surgical Da Vinci platform, is adapting near infrared imaging system in the future. And I can see that what they're really utilizing the near infrared fluorescent guided system is, again, to utilize it as a target and to teach the robots, again, what is visualized as target, which is non-targeted tissue. And again, that can induce safety mechanisms during robotic surgery. Here's an example of a renal tumor under near infrared imaging, again, showing what is not perfused is tumor and what is perfused is normal tissue. Here's one showing the ureter, so as not to cut the ureter under endoscopic robotic guidance. And here's another one showing the differentiation of what a surgeon would see, again, under white light, seeing the perfusion of the renal vasculature, the arterial renal vasculature, and then under a timed manner, what is the venous system coming back with the fluorescence particles. And then you can also utilize it for strictures, again, by perfusing areas within, in this case, the ureter, and where it's blocked, and that can be also done again with endoscopy and also surgical guidance. So I think just to finish it up here, I think multimodal imaging in the future is the way to go. Again, what we are looking now is augmented reality and real-time multimodal image guidance. I think the platform that we would like to use is a wearable device. We have 3 IRBs approved at the Cleveland Clinic, one for skin cancers, one for sentinel lymph node biopsies and breast cancer, and the third in perfusion. So our goal is obviously to tame that complexity into the operating room with these wearable fluorescent guided imaging devices through these digital loops. We want to integrate multiple single point of solutions into one. So you're not looking around the OR, but just focusing on the patient in of itself and into the surgical field. Here's an example thereof of the sentinel lymph node mapping that we're utilizing, replacing the gamma technetium radio tracers. Here's a short video of that, again showing Dr. Steve Gromeyer in real time operating on the sentinel lymph node here with, as you can see, real-time registration. Again, so as of now, I think we have the uncertainty of what's going on with the surgical field. I think we can add different images on this, such as PET scans, fluorescent particle or fluorescent tagged targeted probes, CT scans, to identify, again, the surgical mapping, both in a planning and interoperably in guiding the surgeon, and to be able to do it again, I think, which is really important, in real-time registration. Again, here's another quick video of showing how this can be rotated in many different manners, showing the relationship of the tumor to the animal in all dimensions. Here's another example, again, of real-time registration, locking in to this particular animal, in this case, a scapula, and how we can register this immediately and then in 3D rotate this around. So right now, if I can advance this, here we're registering the scapula within the tissue. And then we're going to start rotating it around. Now that's important. If I can go back, that's important and really surgical planning and in guiding instruments. In this case, the path of a drill for shoulder surgery. And again, just quickly show you how we can guide virtually the drill into the direct path to the targeted area that was pre-planned. And even the angulation of the drill. We can also do this with ultrasound, again, showing how in real time we can register the ultrasound to particular patient anatomy in active motion. So again, I think enabling data consolidation in the OR is very important. We want all this to be integrated into several mechanisms into just one, which will be this digital loops. And again, this is Dr. Gromeyer looking at this area where he can integrate not just fluorescent guided surgery, but in the future, augmented reality for ultrasound, PET scans, fluorescence, and radioactivity. Let me just go ahead because I think we're running a little bit out of time. So we're not far from being Iron Man. I think we're not far from having our situational awareness increase exponentially. And I think it's really at our fingertips, not just for us, but for multiple users within the operating room and it also can be used, I think, by integrating this under HIPAA guidance through telemedicine and looking and adapting for what I call telesurgery, helping others around the world operate and guide them, not just through surgical guidance through fluorescent guided surgery, but also for others to see this to help them guide this through telesurgery. So in conclusion, I think the future is the advances in probes. I think the future is real-time registration on top of augmented reality and artificial intelligence that's going to be utilized for image recognition to produce what I consider personalized precision targeted surgery. So I think I'm out of time.
Thank you very much for that fascinating presentation. We've got lots of questions that have come in, so if you're happy, we'll just crack straight on with those questions. If you want to share your webcam with us, that would be wonderful, Dr. Papay.
Okay.
So while you're doing that, our first question here from your audience. Unify Medical has a wearable device for fluorescence guided surgery. How is that different from Novadaq's spy device and others on the market?
Well, the first thing, it's wearable. So Novadex system is, again, as the surgeons that use it, it's the camera, the light source, and the 2D image is all within the operating room. This is a wearable device. The device, these digital loops that have augmented reality attached to it, can integrate images into the vision of the surgeon in of itself. In addition to being able to angulate at different angles looking at the patient rather than having these large instrumentations. So there's sort of a series of 3 or 4 advantages with wearable devices like the digital loops as compared to the large devices like Novadex spy device.
Thank you very much. And moving on to our next question. The question is, we know that the main limitation of this technology is the penetration of the light. Do you believe that this issue can be resolved?
Again, I think the deepest penetration as of to date with near infrared is around 3 centimeters. With collimated laser frequencies, near infrared frequencies, we can probably get up to maybe 5 centimeters. Compressing the tissue, you're really not changing the depth of penetration, you're just compressing the soft tissue like in a sentinel lymph node biopsy. That certainly helps. But I think there's got to be ways of activating the probes through different types of probes that are targeting the same tissue, i.e. if you have a radioactive probe, i.e. technetium, that's targeting the same tissue as the fluorescent probes, then you can actually see very deeply through the radioactive probe, quite a bit deep. It's not very accurate, but you can see deep into the tissue. And much like landing a plane, as you approach the airport and see the landing strip, as you approach the tumor, then again, these fluorescent probes will begin to light up with the frequency of light that you're bombarding them with, and then you'll know you're getting closer and closer to the tumor.
Thank you very much. And as a reminder to our audience, if you do have any last minute questions you want to send in, then please do so. Any that we're unable to answer today will be followed up with you after the webinar. Our next question here, Dr. Papay, is this technology is not new. It has been published for a long time. Why do you believe it has not become a standard of care?
Oh, that's a good question. Well, I would think I don't think it's. I think a couple things. I think the probes have not advanced. I think once the probes are more targeted to particular tumor types, and that's still in the experimental stage. There's several companies that are going through the FDA pathway and the CE European pathway. Basically we have the picks and the shovels, like I said, but those that identify the diamonds and the gold are still out there yet. So I think we have the technology is advancing quicker than the molecular probes are advancing. Now, maybe that is because of just the barriers of the FDA or the CEA approval. I don't know, but certainly we are more advanced technology at picking up the certain images and integrating those images and mining those images for data than the probes have advanced. So I think that's probably the main reason. Um, Outside of that, I mean, I think once those probes are out there, I think we're ready for them, and I think the safety and your accuracy of the surgery will increase exponentially once again these probes increase.
Thank you very much. And our next question, how much easier to use are the wearable line of sight imaging that you discussed versus the Novadax Spy or handheld technology?
Well, I think they're quite a bit easier in the sense that, you with the wearable devices, you just have to move your head to visualize, particular areas of interest rather than utilizing the camera, moving the light source, looking at a 2D flat panel away from the patient. I mean, this is all integrated into one wearable device, much like we all use, which are loops. So I think the ease of use will propagate this, and I think the cost of these systems, if they are not just the value proposition of the ease of use, but I think the cost of this is much less. I think this will propagate more and more of the utilization of fluorescent guided surgery in the OR. Right now it's a hassle, but as these easy to use wearable devices come into play, I think in a much less costlier manner, I think we're going to see more and more use.
Thank you very much. And just keeping an eye on the time, we'll just take another couple of questions from your audience. A question here, do you have experience in either a false positive or a false negative image when visualizing a tumor with this technology?
So repeat the question again. I'm sorry, I didn't hear it.
Yeah, the question is, have you had experience of either a false positive or a false negative image when visualizing a tumor with the technology?
Well, there was one recent study. Again, one is by Dr. Gromeyer and another one is by Dr. Gassman out of the Cleveland Clinic. Dr. Gassman showed that there was an increased sensitivity in his melanoma, slightly increased sensitivity in melanoma sentinel lymph node biopsies. And according to Dr. Gromeyer, he's also felt the same increased sensitivity and specificity for sentinel lymph node biopsies in breast cancer, intraductal carcinoma and breast cancers. So they are improving. The value proposition of using ICG for sentinel lymph node biopsies in both breast cancer and melanoma, number one, which I think is great, is it obviates the need for nuclear medicine and technetium radioactivity, which improves the safety not just for the patient but for the surgeon. Number two, it improves the time of the flow of the patient from going down to nuclear medicine and going back. And if you can show that, which has been shown by Dr. Gromeyer and Dr. Gassman in recent studies, I think Dr. Gromeyer has not published that yet, but Dr. Gassman published it a few years ago. There's no reason, again, to use these radioactive particulate, tags that you can just go directly to fluorescent guided surgery and just use ICG.
Wonderful, thank you very much. And moving to our final question, how important is it to integrate CT and MRI with the fluorescent imaging? Do you need multiple modalities in most surgeries?
Well, most surgeries, that's a hard question to answer because there's thousands of different types of surgical cases. Just look at the number of CPT codes. So I would say in tumor-targeted surgery, on the surface of the body, you probably do not need it. Just underneath the surface of the body, i.e. sentinel lymph nodes, you probably don't need integrated images. within the body, i.e., the lung cavity, the abdominal cavity, then I think you're going to need integrated images, i.e., the liver, the bowel, etc. So I think depending on where's the anatomy that you will integrate in your surgical field will answer that. So superficially, no. Deeper, yes.
Thank you very much. So that is all the time that we have for today, and it just leaves me to thank you so much for your presentation, Dr. Papay. That was very engaging and enlightening. Thank you also to all of our audience for joining us today on our webinar. Once you leave today's webinar, you will receive a survey on the presentation. It's just really a quick couple of questions, so we would be grateful if you could keep your browser window open and complete that and provide your feedback. You will receive a follow-up email within 24 to 48 hours, which will include a link to a recording of today's webinar. On behalf of Diagnostic Green and our presenter, Dr. Papay, thank you so much for joining us, and please do all enjoy the rest of your day. Goodbye.
Thank you. Bye-bye.